welcome all of you. So my name is Imran Mateen. I'm the Executive Director of the Brac Institute of Governance and Development, which is a social science research and a postgraduate teaching institution within Brac University. We have launched a rapid research response to COVID-19 on 30th of March. And we have embarked on a series of rapid surveys and qualitative studies to be able to provide useful, reliable, and rapid evidence and insights for all kinds of decision makers involved in taking decisions with government and with NGOs to be able to actually design more effective interventions. So as a part of that, we are going to be presenting today Dr. Shahiduzzaman, who is a reader at the Brighton and Sussex Medical School. He's a reader of anthropology and global health. So he was the PI of this particular rapid qualitative research that we conducted in roughly 12 days. We have completed the research and we are presenting right now. So all our research that we're doing right now takes a span of about 12 to 15 days within which we complete the research and get the results and basically come and present to all of you. We are trying to build a culture of rapid and reliable research. So whilst our research is rapid, we also believe that this is also a time when we also cannot compromise in terms of the reliability. We just need to find innovative ways through which we combine and balance rapidity with reliability. So that is a particular focus that you would basically see in all the work we're trying to do, where we're trying to combine it being rapid and reliable and relevant at the same time. So this particular research that Dr. Shahiduzzaman has conducted, and you'll hear about it, is focusing on one particular problem, which is the problem of communications. Now, we all know that the COVID crisis is primarily a health crisis that has led to economic crisis. And I think we're increasingly talking about the governance crisis around COVID. But I think one of the underlying crises that is really fundamental is a crisis in communications, because at the end of it, any epidemic, and COVID is a very serious epidemic, at the heart of it, it is behavior change and communication. So behavior change, communication, and community engagement is at the heart of any intervention. So this is exactly the research that Shahiduzzaman Bhai has conducted, and we will be listening to that. So without further ado, I'll stop here and ask Dr. Shahiduzzaman to make his presentation. Just a few points of housekeeping. We're not going to entertain any questions while the speaker is speaking, because it gets just impossible to manage. We'll wait for the speaker to finish. We'll all be on mute while the speaker is speaking. After the presentation, we can ask questions. The predominant way we want to ask questions is through the Zoom chat. I've got colleagues who would be monitoring the chat box and giving me a synthesis of some of the questions, which I will be using to basically get into conversation and discussion. But if there are people who also want to speak, please raise your hand. There's a hand raise option, and wait for me to ask you to speak. And then once you have done your done with your questions, please go back to mute. So let's really ensure we sort of maintain all these Zoom hygiene to be able to have an effective and productive conversation. We're also broadcasting this on live Facebook Live. So, obviously that's another opportunity there for you to sort of participate as well. So I'll stop there, and I'll invite Dr. Shahiduzzaman to make his presentation. Thank you very much.
Right. Thank you, Imran. Can you hear me? I mean, if just some Imran, can you flag that you can hear me?
Yes.
I'm having a bit of, okay.
No, we can hear you well, Shahiduzzaman Bhai, I think.
Right. Okay. So yeah, I've been having some technical difficulties. Okay. Thank you, everyone, for joining in this very strange time. and I'm pleased to join from from a very distant continent, and thanks to the technology. So I should probably share the presentation, isn't it? Let me check. Yeah, I'm also trying to use to this whole. Why I'm having problem sharing the screen? Give me a second. Yeah. Really.
সাধুজামান ভাই আপনাকে শেয়ার স্ক্রিন থেকে আপনাকে যে শেয়ার অপশনগুলো দেখাবে ওখান থেকে আপনার পাওয়ার পয়েন্টের স্ক্রিনটা চুজ করে আবার শেয়ার ক্লিক করতে হবে, শেয়ার দিস স্ক্রিন, ওখানে উপরে একটা ডায়লগ বক্স আছে।
It's really getting problematic.
So can someone else share, please? Nusrat, you have the presentation. Could you please share?
Let me do it from, because I saw it right now. Oh, this is really problematic.
Sadhu-Zaman bhai, should I share from my screen?
Give me a second. I think I'll be.
Okay then.
Yeah, can you see?
Yes, we can see. It's coming. Yeah, good.
Right. Okay. So,
Niche, why don't you press that full screen, Niche? Then we can. I think it'll give better visibility.
Is it all right now?
Yep, that's fantastic.
Right. Okay. Sorry for all this technical problems. So, right, as Imran just has said that this was a rapid study, but I would say it was a super rapid study, which means very unusual for me to be involved in this. Too rapid with the too rapid time space. But of course, given the time, we had to sort of cater to this to the demand. But as again, Imran, you mentioned that this was a crucial thing to explore. Before I go into the study, just briefly about the research team, as it was actually a joint research by me and Dr. Shumon Rahman from University of Liberal Arts. And thanks to Mehnaz Rabbani for coordinating the research, and of course, Imran Mateen for facilitating the research. I would also like to thank the research associates who really helped in collecting all this data: Farooq Hussain, Tanvi Shatil, Dipannita Ghosh, Kamruzzaman, Sajia Sharbin, Samia Said. Briefly, some background thoughts. As we all see that there are ample of information and advice on COVID-19, but hardly these are followed. So we think that there's a gap between this information and the enactment of this advice and the enactment of these advices. And this is a communication crisis. But we also argue that epidemic is generally considered as a public health, economic, and political crisis, but underplaying the crisis of communication. Communication is also an important crisis of any epidemic or outbreak. And it's also important to acknowledge that communication doesn't work in a vacuum. It works in a particular context, in a particular life world. And it's important to understand the life world of the recipient of this information and the advices, how it's being received within the context and the life world of the people that we are targeting at. And disease outbreaks transmit through social routes, and it's important to have insights from the social science to understand this whole disease outbreak and its transmission. And broadly, the aim of this study was to understand how the COVID-19 related information are being received, interpreted, and enacted within the everyday life of the recipients. And we took an anthropological approach. I mean, anthropology is kind of a discipline that don't rely on statistics, numbers, graphs, or would like to go to understand the stories behind the numbers, behind the statistics, and would like to understand the real life context of where all this information are being enacted, received, and understood. But anthropology depends heavily on observation, but given the current context, we had to innovate different methodologies and tools and triangulate to get a valid result. So we conducted telephone in-depth interviews, and we from 4 different clusters: rural, district, urban slum, and urban middle class. And we have interviewed 82 individuals from all these 4 different clusters. We also collected data from through netnography, which is a kind of ethnography, or it's a category of ethnography where we observe people's online behavior. And we also did a shadow participant observation. Participant observation is an integral part of anthropology. But again, given this context, we dependent on observation of a trusted source. We also exchanged visual photographs and photo narratives. So this was another way of conducting participant observation. I'll just broadly present some of the findings from this study. What we found that there are definitional crises. I mean, the advices, the information that are being transmitted, and the terms that are being used, people are a bit confused with the definition of these terms. For example, they're being told to stay at home, but the whole concept of home means different thing to different people and from different socio-demographic condition. For example, in a rural area, in village, the home has different meaning. I mean, there are units of ghor, bari, and para. So a home does not only, it usually comprises, sometimes it comprises a number of houses, a number of homes. For example, a Sharkar Bari is a combination of 3-4 homes. And when they talk about their mobility, their unit of mobility is para. So when they're asked to stay at home, they try to restrict their mobility within the para. So that's they're happy that they're within the para. So there's a confusion about the ghor, bari, and para. In the district town, their unit of mobility is mohalla rather than when they talked about their mobility, they talked about their mohalla. For Islam, it hardly, the home hardly means anything. It's just the room. So they talked about corridors. For example, in an Islam corridor, they have 3, 4, 10 to 8, or sometimes 12 rooms. So that makes a corridor. So that's their unit of mobility. It's only the urban middle class in Dhaka who meant home. I mean, who mentioned their own flat as their homes. So again, to what we found that stay at home means different thing to different people. It's just a kind of, we did a lot of data collection from people's online comments, posts. So this is an example of a post from someone who talked with a rickshaw puller and his understanding of lockdown. So he mentioned lock is tala and down is niche. So he understood it. It's something the lock has broken down, something like that. So people have made different meaning from these terminologies. The same goes with social distancing. When we say social distancing, it's almost a mere impossibility in a slum context. It doesn't, I mean, it's almost impossible to maintain social distance in a slum context. In a rural and district context, maintaining social distancing, it's very challenging. It could be disrespectful, and it's very difficult to come out of this I mean, old cultural code of I mean, we have a culture of proximity. It's a hugely, it's a culture of proximity between people. So it's not easy to just practice social distancing overnight, and it is sometimes considered disrespectful. And for urban people, it's claustrophobic for many people to maintain social distancing. So again, social distancing meant different thing to different people. So what we found that all these directives and the advices, for people, these are administrative orders rather than life-saving mechanisms. So they try to find various tricky ways of avoiding these orders and advices. I mean, many of you probably are familiar with this this image. People are trying to sort of travel inside a drum. There are a number of examples like this. I have few clips. I don't know whether that might be technically a bit difficult to show, where there's a CCTV clip that shows exactly what we are trying to argue. Well, people are loitering and just gossiping. It's only when the police comes and it's just within a second the space gets empty. So this is exactly demonstrate that they hardly related to life-saving mechanism. Rather, they just want to it's just to avoid the surveillance and monitoring system. And to follow and follow these directives. It's also important to understand how people understand this some of the visual ways of disseminating this whole corona epidemic. There's again another, probably many of you have seen a elderly person from a village who is when he was asked what is corona, and he said that, okay, yeah, I've seen something like a circle and a big ball, which is just rolling up in the TV screen, and if it really hits people, that definitely people will be killed. So the point, we might laugh at it, but the point is, we have this assumption that people have the microscopic understanding of microscopic beings, but many people don't have this insight of microscopic world. So they take these images literally. So this may mislead people to understand the exact nature of this disease. Also, regarding hand washing, what we found that there's a huge emphasis on using soap. People mentioned that they have increased the number of times they wash their hands, and every time they use soap. So there's lots of emphasis on using soap, but hardly anyone could say about the exact procedure of hand washing, because it's very important. The way hand is washed. This is an image that we collected from the rural in some villages. It may not be very clear, but in all the tubules they have hanged soaps for quick use. So it's like people are using soap in various innovative ways. But there's a confusion about exactly the procedure about hand washing. There's also confusion about whether people need to wash the hand for 20 seconds, 20 minutes, or 20 times a day. So there was confusion about the way hand washing needs to be done. The use of mask also, I mean, the meaning and use of mask also varied in different groups of people in different socioeconomic clusters. Again, what we found that mask is being used as a ritual, mostly for ritual to fulfill the government order. And we also found that because there is a global confusion about using of masks, some country they made it mandatory, but some country thought it's not that effective. So that confusion also has been transmitted in local level. In Bangladesh also, people are confused. Many people said, okay, because there is no consensus, we're not sure whether we should use it, and there's no clear directive about mask. There's also a status variation within the mask. So people who are having N95 feels a bit having a higher status, and people want to use N95, and those who can't afford N95 consider themselves as not belonging to that particular group. Masking can also be unsocializing. People also in our culture, it again could be disrespectful, and we observe that. So people, when they're alone, they use the mask, but when they engaged into interpersonal talks or discussion, they take off the mask, which is even dangerous. So this is again just a cultural way of using mask. If someone wants to draw sympathy to someone else, a lower socioeconomic group, people, they don't want to use mask because they think that mask would sort of, it's a tool for apathy. And we got, I mean, there are examples of now crimes, unlawful acts using mask. So mask also have different narratives. Regarding the disease management, we found that that's confusion across different locations, starting from the urban middle class to rural and the slum population. People were very confused what to do if someone in their family are affected by corona disease. People mentioned about IDCR phone number. Some of them didn't have good experience of using the phone, and for rural people and for slum, the unresponsive phone number also generates even more fear, and it's a bit abstract thing to really contact. So they basically, when they were asked what you will do in case someone is affected in your family, they mainly talked about their own existing in line of their existing health-seeking behavior. They talked about going to local pharmacy, Thana Health Complex. Some people talked about going to medical college, district hospital, and urban middle class. They basically they don't have a clear plan, but they said, okay, they will use their social capital. They have friends, doctor friends, and they know someone who is a doctor. So there's not a very clear understanding exactly what needs to be done and what are the options. If one option fails, what needs to be done as an option B. So we found this confusion across different geographical locations. The source of information also differed. In rural area, it seems BTV is still quite popular. People get information from street miking or also from the mosque. But in any case, they always verify the information, whatever they get, through interpersonal discussion. The people are like a kind of a peer filtering. In the district, it's mostly cable TV, street miking, social media, and also interpersonal discussion. For the slum dwellers, it's cable TV, and they get the information from their employer. Interpersonal discussion again plays an important role. It's just that they always want to verify the information they get from different sources with someone whom they trust. And use of social media is also, I mean, it's common in some slum dwellers. For urban middle class, they cross-check information from different international media, BBC, CNN, Al Jazeera, and also have online discussion and indeed use the social media. We observe the print, visual, and social media content. We think that there's an oversensitizing of the crisis. Sometimes it's a bit dramatizing incidences and kind of creating a sensitizing, sensationalizing the whole thing. Again, some of the global confusions about the information and messages being transmitted to local level as well through these different print, visual, and social media, which is, I mentioned about this mask confusion. There are also region-based rumors of remedy and different kinds of invention for prevention, remedy, and this has been sometime broadcasted in various media without being critical to it. We also have seen conflicting information coming from Islamic preachers, which was more prominent in the initial phase of the epidemic. So this also created confusion. So this is what we call infodemic. This is a term we use to denote it's kind of an epidemic of information, which is an excessive, conflicting, and unclear information, making solution more difficult. So if we see the whole information and advices from the point of view of the recipients, so as social scientists, as an anthropologist, we play a role of kind of a cultural broker and try to mediate the voices of the recipient, and what we see from their point of view that they are kind of confused with this excessive, conflicting, and unclear information, and it's becoming challenging for them to really come up with a proper solution. So this is like an epidemic. This is a kind of an infodemic that's they're going through. So our summary reflection is that we think that some of the global messages that has been generated globally, mostly in Western countries, had been uncritically transferred to Bangladesh, not always fitting to the local reality and the life world of the individual people of our setting. And there are certain assumptions when always the message and information are being constructed based on certain assumptions. Again, we have given these examples of when we say home, we have certain assumptions about home, which the assumptions are not always based on the target population that we are thinking of. So the assumptions in many cases are faulty. See, not just this, I just mentioned about home, but all these different terms. I also mentioned about this microscopic image and understanding of microscopic image. There's an assumption behind portraying this graphics with the assumptions that across the socio-demographic clusters, people would receive it in the same way. so there are problems with the assumptions behind the construction of the information and advices. And we also think that the confusion, unclear information actually generates more fear and also stigma. We have also already started to experience that there's an kind of fear is generating. There are lots of stigma is going on, and there are sociological theories about liquid fear. How if things are unknown, things are unclear, people get even more panic. So the one way to deal with this is to structure the reality, and one way to structure this is to provide proper, clear information, so that the strength of information, it looks like, has not been fully acknowledged. And to us, the whole information flow and the information transmission strategy that are being followed currently is kind of a peacetime communication, but it actually, we are in a wartime situation. Indeed, it has been used a number of times as we are battling against an invisible enemy, and that needs almost like a wartime strategy of communication and information dissemination. And for that, I think it's important. We think that it's important to think out of the box in communication mechanism and communication procedures. We, again, as a social scientist, what we try to do is to come up with an insight, a broad insight, but we're not in a position to really provide a concrete recommendation about mitigating these issues, but we'd like to just present certain recommendations which could be considered who are directly involved in this communication application. So we thought that it's very important to have a coordinated and targeted message definition. It looks like not much the information are being disseminated, given from different sources, and sometimes it's conflicting, and there's no coordination. I can speak from the experience of living here in the UK. They ensured one thing is that the information comes from a single source and very specific targeted messages, which I think is important. That's something needs to be, we need to pay attention to have a coordinated and targeted message definition strategy. And we also thought that it's probably important to cluster the message for different socio-demographic group. If possible, for the information that's relevant to slum may not be relevant for the rural poor, and definitely not for the urban middle class. So just a blanket information probably would not work. We also think that it's important to avoid sensationalizing the news, and rather important to highlight some of the positive news, the positive initiatives, the strength of our general people, local people are coming up with lots of informal initiatives. And it's in this current context of fear and extreme uncertainty, it's important to create a positive environment, and media can play a very important role rather than making people more confused. And as we have seen in some media, they have publicized false claims of cure and remedy, which I think it's very important to be careful. So these are, we have divided the recommendations into three levels. So this is national level recommendations. We think that certain things could be done in the community level. Again, this is linked to the national level interventions as well. I think it's important to define the term that we just discussed. I just discussed all this global terminologies, and to operationalize this terms and advices, keeping the local context in mind. Just an example of this social distancing. If it is, if for people the unit of mobility is para and mohalla, should we think of something that fits to their understanding, and that's actually, it's possible to practice within their own unit of mobility, unit of residence. I just mentioned here this experience of ORS. We know that at one point, Brac actually has popularized this whole ORS message and made it localized or contextualized with this whole ek mutho gur and lobon ar pani, so this molasses, salt and water, which was of course not 100% scientifically correct, but it was just by contextualizing it, it was possible to at least cover a huge number of population. So there's a balance between the absolute science and the local reality. So I think it's important to think through this. People might say, okay, the ideal way of ideal advice is to stay at home. But if it's impossible for a slum dweller, what we do, can we operationalize it? Can we contextualize it? Which may not be 100% the best possible solution, but something closer to the best. So it's important so that people would relate to this message. Otherwise, it doesn't make anything to them. That, okay, you maintain social distancing in a slum condition, in a rural context. So the people enters into their ghor, into the house only during the night time. So it doesn't make any sense to ask him to stay just in a home in a slum context or in a rural context. But it's just a thought that can we operationalize it? And for that, it's very important to have, again, maybe a brainstorming, more dedicated thinking, and innovative ways of coming up with solutions. Just this is an example many of you probably have seen in a rural hut. I don't know exactly where it is. So people, even people also have ideas how to come up with ideas about social distancing. They have come up with a fantastic social distancing, a bazaar with maintaining social distancing. And at the individual level, again, if there are certain things that can be done just within the individual level, if we cannot do all this macro level interventions, it's possible to do certain micro level interventions. I've given this example. I've read an article from Nicaragua. They suggested their slum dwellers, if you can't do anything, at least do two things. One is just sneeze in your elbow and clean the most frequently used surface of your house. That is something within their capacity to do. And that's, if we could encourage them at least to do that, that would also reduce this whole transmission to a great extent. It's also important to have visual demonstration of the hand washing. These are two very important things. Hand washing is a crucial thing for this breaking the transmission. So it's not just wash your hand doesn't actually really make a big difference. Rather, unless we give them a very concrete demonstration how this needs to be done. And the other thing we thought would be very useful to have a clear flow chart, particularly of disease management and also dead body management. We know that there's lots of confusion going on around dead body management nowadays. So I've seen this flowcharts being used in different parts of the world. Again, in UK, despite the fact that they know about the health system here, but they still provided very clear, concrete flowcharts for what needs to be done and what are the options, plan A, plan B, plan C, something like that. So I'm just giving you some examples. This is a flowchart for this whole isolation practice, what needs to be done in terms of in case of self-isolation, a demonstration of hand washing, also kind of a guideline for like preparing oneself in different phase of this epidemic. Again, these are made in an European context, which definitely cannot be just transferred uncritically to our context. It's very important that we sort of translate it into our context. But the point I'm trying to make is that these are some of the examples of flowchart. I think it's important to have, instead of giving just a broad message and advice that just call this and that number, it's also important to give a flowchart, what exactly needs to be. I talked with my even doctor friends in Dhaka and asked what you'll be doing if you get infected. And I saw confusion in their narratives, that they don't have exact pathways, that what needs to be done, what first and what next, and all this, the pathways of care. So I think, yeah, I've probably towards the end of my, that's the last slide from my side. Again, this we have more, a lot of other findings. I thought I'll just give some of the broad findings and broad themes and ideas that emerge from this particular study. But I'm happy to have any comment and question. And I would also encourage my co-researcher, Dr. Shumon Rahman, also to join. Thank you very much.
Thank you. Thank you very much, Shahzaman Bhai. So just before, I've been collecting questions. Let me just first go through some of the questions that have come through in the chat box until now. But before I do that, I just want to be mindful of timing. So we started about 15 minutes late, so it's 4:52. We'll go until 5:15 as the kind of official time where we want to stop. But after that, if there are questions, we can continue sort of depending on where we are. But let's aim to finish by 5:15. I got a number of questions, and I won't go one by one or go exactly name people. So Shahzaman, there are about 10 questions that I kind of identified here. So let me just start with a few, maybe take a cluster of four to five at first, and then we can see what happens. So I think there's one question I think is a really, really, really important one, which is around it seems that the interconnectedness of behaviors is something that is not really working. So, people are looking at individual behaviors but not really seeing the interconnectedness of different kinds of behaviors in terms of the sort of actual impact that it can have. So the mask, the distance, the wash, the interconnectedness of behavior. So that's sort of one. What are your thoughts on that? And, I guess if you can also offer some thinking in terms of what can be done in terms of getting to this interconnectedness of behaviors. There are questions around the time dimension. This is again something that's really critical, the 20 seconds, how to indigenize that time dimension, given that, lots of people don't really have a very, kind of same way of thinking about time or looking at time. or has it really changed in the context of Bangladesh so significantly that actually the time dimension, 20 seconds, people get it, and it will actually work pretty uniformly. So it'd be good to hear your thoughts on this time dimension. There are questions around, kind of ideas around, local languages, use of local languages, use of religious preachers, which is of course we know from other, kind of BCC information interventions, it's absolutely critical in ORS. This has been fundamental in terms of using religious preachers, but would love to hear your thoughts on that as well. And we know the role, the mixed role that religious preachers have been playing, and what are your thoughts on that? And then finally, I think the cluster of questions around fear and stigma and the whole importance of destigmatization and de-othering, and then your thoughts around that. And then the last question is around gender, the gender dimension of social communication. So I think those were some of the, I'm sure you have written down 5 or 6 kind of, areas.
Right. So if I may just repeat, so you initially talked about interconnectedness of the information, and also the time dimension. You talked about gender, you talked about fear and stigma, and what was the other thing?
Well, I think I talked about the religious preachers. I think that's really important.
Religious preachers, right. Okay. Let me begin with the fear and stigma. Actually, Shumon and I am also involved in another study where we are trying to explore this whole fear and stigma aspect. That's being. We see that it's emerging in a very. When we are all concerned about this whole thing. So it's briefly, the stigma generates when. Again, and from sociological thought, when there is a spoiled identity, it's a deviant. You make others, like othering of people. So we see that there is kind of a there has been an othering process of this disease, and the people who are has been targeted to being like others as a spoiled identity. Which started with the migrant returnees, and then it transmitted into just with just the local patients, and even to the health workers, doctors, and nurses. So we are exploring this whole pathways, how this whole stigma process emerged and actually circulated from the state to the community. So that I'm not going in detail into that, and we have some very interesting finding, which probably we could have the opportunity to share later on. But I would say that I briefly touched on the fear is generated basically when something it's from 2 sources. It's extremely unknown and deviant. So this particular disease is deviant in many sense. It's a disease which doesn't have any cure, no vaccine, and usually we have this notion that okay, if we can't manage this in our country, maybe the Western world and the high income countries would be able to manage, and we see that even they fail to manage it. So it actually generated this whole unknown nature of this fear. But the problem is we had a false sense of safety from the beginning. People, and that we are trying to get this sense where this false sense of safety came from. This so I would say to mitigate this fear and stigma, it's very important. Again, the communication and information would play a very, very crucial and critical role, and we will only be able to get hold of the fear or the unknown if we can structure this whole episode, and we can only structure the episode through proper information and making it understandable to the people. Again, that brings to this whole issue of localizing, contextualizing the issue. So in terms of fear and stigma, definitely information, and we have to understand the source of stigma and fear, which I think from a separate study, we have a bit of better sense now where this fear is coming from. Using the religious preacher as unfortunately, in this particular episode, initially, I just mentioned about this false sense of safety, which was also generated through Islamic preachers. And unfortunately, they had this narrative that, yeah, this is something foreign to us. This is this is something foreign, and the people who there's always a moral judgment of this disease, which has an historical root. So many religious preachers initially kind of narrated or preached this idea that we don't have to be afraid of this thing, because this is a foreign thing, comes from a country where they have immoral lives, things like that. But I see that there's a change in the narrative even within the Islamic religious preachers. So, I mean, you mentioned about using the Islamic preachers in Waris, which is, and not just for Waris, but for many health education, religious preachers have been used. But we have to be careful that this particular epidemic is not like any other disease or a health condition. This comes with a particular moral baggage, and it has a huge historical kind of connotations. So we have to deal with that separately. It's not like a diarrhea that doesn't have any moral meaning attached to this. So it's important that we definitely pass this message through religious preachers, but we have to negotiate and bring them on board, and their understanding and the scientific understanding needs to come to a particular zone where it sort of then it has to be a consensus. Definitely interconnectedness that's missing now, and I mean the information it's kind of a silo information. How this social distancing, quarantine, isolation, hand washing is linked each other, and how the disease management and all these advices are linked. So that's missing, and that's exactly the point I was trying to make, that it's important that we pay attention to this interconnectedness. Not being this, certain people are not afraid of this disease, and that's also a source of fear for others. Certain people don't think that this threat provides any threats. So how to, I mean, the scale of the problem, the scale of this whole issue has not been realized by many people. But of course, there are issues of extreme livelihood issues where, I mean, the fear is also related to that. I mean, I would, if my livelihood is at stake, no fear is as near as my livelihood, as my food. So that we also have to consider that. Gender is definitely a very important aspect. We also explored some component about gender in our study, which I didn't present here, which is a bit different. But generally what we found that there's within this whole lockdown situation, women are being rather more pressurized because we are asking, I mean, we know traditionally women are considered homemakers. And if we ask everyone to stay at home, then home becomes the whole arena of all activities, and it's the woman who needs to take care of this extra burden of this whole homemaking. So we have lots of narratives where women are being overburdened to maintain a home. And child rearing is becoming a huge challenge, where the school is closed in the urban, in the slum area, even when they could get rid of the children at the field and they could do their own work. But that's impossible now because they're forced to keep their children close to them in rural areas. So there's lots of gender. I mean, we know, and there are examples of increased domestic violence internationally, also in Bangladesh, because when like you are sort of all within a household, and if there are existing tension between relationship, this can flare up into lots of violence. Right. So and the time issue, I didn't exactly get the time point. Are you talking about? I mean, what was the question exactly?
Well, I mean, the question was this whole 20-second thing, and given the given in the rural areas, given illiteracy, I mean, how is this the best way to sort of communicate the time, or are there other more creative ways that one should be thinking about the time communication?
Time, you mean the
20-second to wash?
Oh, right. Okay. Yeah, I think again we have to. I mean, we cannot be just. I will again bring the Waris example. When we talked everyone to have like ek mutho gur. Ek mutho gur was never the exact amount of the recommended glucose that's used in a Waris packet. But we have to maybe, I mean, 20-second brings. I mean, how do expect a slum women to count 20 seconds? Do they have watch with them? So we have to operationalize. We have to find a way to make it as close as possible to the science and to the reality. I would request.
If I may interrupt, sir.
Yes, just Shumon. I was about to ask you to comment.
Regarding this, time. Just one thing came in my mind, like if you ask people to recite something like that Surah Al-Ikhlas, which takes some 30 seconds or more than 30 seconds to finish, and while they are washing their hands, so you just wash your hands and you recite Surah Al-Ikhlas for Muslims, it would probably work. This is just an example. So you can operationalize in many different ways. This could be one example, that you recite something, very important, virtuous, or, pleasant, and you just wash your hand. So, this is something that I can add.
Yeah, even I would, Imran, I mean, if you really think of, innovation, I mean, I've worked in field for many years, and I have lots of interesting examples how people actually operationalize various directives according to their own means. Again, this in time, I remember there was one Shasto Shabika. He used to. I mean, he was asked to count the breathing to diagnose pneumonia. So, I mean, he doesn't have, like, if it is more than 20 breathing in a minute, then you have to refer this patient to like in a referral center.
Great. So Shadazam, just I'm just trying to kind of manage time and all that. So sure, I think there are a number of other questions, but I would also like to give some time. Maybe some people want to just ask questions directly. So maybe we just take a few questions, but if you can be really brief as you ask your question. I know that some people wanted to just kind of elaborate on their questions a bit. So why don't we do that right now?
Sure.
If you could raise your hand, and I think I should be able to see the hand raise. Shadazam, could you just take your screen off? So I think then I could see everybody.
Okay.
Great.
Should
So,
be a stop sharing, yes. Stop sharing button somewhere.
okay, as people, I can't see anybody raising their hand, but maybe you're making.
Hi, Dr. Abdul Hussein and Inam from Campi.
Okay. All right. So yes, please go ahead, Mr. Abdul Hussein. Maybe you're on mute. If you could unmute yourself.
Hello. Now
Yeah.
it is okay?
Yes.
Okay. My name is Abul Hussain, not Abdul Hussain.
Yeah, please go
All
ahead.
right. So Sadhu Jawan Bhai, I would like to, this is not my questions. The findings so far you have presented as a methodology, that is all right. There is no problem, but as a sociology student, I also understand your methodology, the anthropological methodology. We always talk about the anthropology, the participant observation. But I would like to thank Dr. Sadhu Jaman Bhai and his team. There is an innovative methodology while we are facing such a condition, quarantine condition, how can we participate with the participants? There is a new methodology, but my suggestion is we need a session on the methodology, anthropological methodology, how to cover from the distance. That is very important. So I'm not critical at this moment, but I think this is innovative at the moment. Okay, thank you.
Thank you. Thank you, Dr. Hussain. Yes, methods is one thing we will be writing on.
Very quickly, Imran, I mean, that just to respond, yes, that's why we have innovated certain methodology. For example, this shadow observation was a innovative way of doing observation. If we have time, sometime later, we could elaborate on this.
And I think the report that will come out, so we will be writing up a report. We will be, kind of having a good section on method, because I think you're absolutely right, Dr. Hussain, this is important. Great. So are there, Inam Bhai, you wanted to come in?
Yeah. Thank you, Shahaduzzaman Bhai, for the nice presentation. When listening to you, I was recalling many of the issues. I'd like to focus one or two. For example, the lockdown, the meaning of lockdown, how you have seen the meaning of lockdown, and what are the deviation in application of the lockdown. That is one. Number two is when you were talking, I could recall that the source of contamination has been considered as the migrant worker is one of the major sources. So those who are one of the major source of our remittance, and somehow during this pandemic, they was considered as our opponent. So will it have a long-term implication on our social structure or economic structure? And the final word is, what are the one or two key issues that as a development practitioner, we should take in mind when we resume after COVID? Thank you.
Right, thank you. Yeah, very briefly, again, yes, I mean, this, I was talking about this othering. So when you identify, you make someone a deviant from the normal, and it was the migrant workers or the migrant returnees who were made others at the very beginning. It already had an impact on them and on our society. It's difficult to predict what will happen in the post-corona world, but I guess we have to pay attention to this in order to undo this stigmatization of migrant workers, and we need to pay particular attention to that. It might have long-term implication. In terms of lockdown, as we have shown that, yeah, people have misleading understanding of this whole lockdown. I don't know, but Shumon, do you have any comment on that specifically?
Okay. Basically, lockdown has a connotation which reminds many of us as another word, which is lock up. So meaning you are imprisoned. So that is one of the reasons why we see people are fleeing from their isolation facilities. So this particular word is problematic for this for our population. I guess we may choose different word different Bengali word to replace it. And regarding these migrant workers, well, one of our observations were like, although all are migrant workers or people coming from abroad, but we saw different treatments for people who are coming from different regions. For example, people coming from the US are not treated with same stigma compared to people who are coming from, say, for example, Middle East or from Europe. So this is the difference, which is actually the prevailing, which supports the prevailing class structure. So, if you ask me to assume, I don't think this, this stigma will prevail as soon as the pandemic is over. But you need a different research to examine this after the pandemic is over. Thank you very much.
Just to add, yes, I mean it's an historical. I mean one of my area of work in research work is history of pandemic. So this is not new. In any pandemic, historical pandemic, there has always been people who have been victimized. Certain people have been victimized. In internationally, and in this case, Chinese people were being victimized because of the corona. The American president called it China's Chinese virus. So that's also kind of a racializing the disease. So this similar kind of thing has happened to migrants. But you have to just remember that we also have, like in our cultural world, this whole idea of ek ghore kora, kimba ghor bondo kora, kolonkito bari. So it fits with this whole historical cultural practices. If you isolate one house, and nobody wants to be stigmatized and ek ghore hote chaye na keu. So that why people are fleeing, even hiding their diagnosis, has cultural roots. So that's we need to understand. And your other question was about post-corona. That's a long discussion. I mean, we are going through an unprecedented time. It's a century kind of experience we are going through. Nobody was prepared in the entire world, and it's completely unknown territory that we are entering. I think different country will have different implications, different experience in the post-corona world. That's why I would like to emphasize that we try to understand our reality as much as possible. Not just taking the framework, understanding, analysis of the Western and global way of understanding things. We are going through a different. We have certain strength, we have certain limitations. And just the last thing I would say that it's the first time we have this sense that West or Europe is superior in all, in terms of health system, in terms of knowledge. But some of the social scientists have been challenging this idea, but the COVID has actually exactly showed that they are also unable to this is a threat to the supremacy of all these Western ideas. So I think it's important that we pay attention to our own indigenous strength, understanding, and knowledge.
Okay, I think we have crossed the time, but maybe we'll just continue for another 10 minutes or so, because there are a few other questions and some people wanted to really also sort of come in. So in terms of questions that has come, one question, Shahiduzzaman Bhai, that I think is, you talked about the peacetime, wartime communication. So from that wartime communication point of view, is it, there's a possibility that there may be too many noises, and it will create difficulty in sort of targeting, specific people. So, if you want to customize too much in a wartime setting, wartime setting often requires a level of standardization as well, right? So how do you, I think there's a bit of a balance, right, between customization, standardization, and scale, all of that. And I wonder what's your thought on that?
Right. I mean, of course, but I'm not in a position to really exactly recommend what needs to be done. But what I think is to come up with a solution. The first thing is to understand the problem. We need to pay attention to really understand the problem and spend some dedicated. What I have seen some practice, for example, I've just experienced. Some people have shared some communication material with me and our team, and I can see that not much thinking has gone through this while making this communication material, keeping this altered reality, altered context in mind. So if we could at least dedicated time for brainstorming, just first to like keep this new the reality that we have just talked about. Maybe there are other research have been done. Not aware of all this, and then come up with as you rightly say, that we have to have a balance, but that's not impossible. It's not impossible to even cluster messages and information. And I would say that it's important that we have a dedicated time to discuss on this, like the people who are really involved. Our role as a researcher is to provide insight, and those who are expert in communication studies, it has to be evidence-based, and maybe a multidisciplinary discussion is important, and that doesn't require a huge like a time frame. Just a 1 day, 2 day discussion should all right.
So on this, I think I would just like to bring in Khairul Bhai. Khairul Bhai, if you're still there, because I was quite intrigued by what you wanted to really come in for. So if you're still there, so maybe we would love to hear you.
Oh yeah, I'm still here. No, I just wanted to give an example that can you hear me?
Yes, Khairul Bhai, we can.
Yeah. So I just wanted to give a live example of, what can go wrong if some of the evidence is not being used by the content producer. And you might have seen that all the hand washing messages we were showing, the hand needs to be, both hand needs to be used in hand washing. That's what we are showing. And it requires running water. Now in Bangladesh, the percentage of piped water at household level is only 85%. It's in rural areas is 2.5%, in urban it is 37%. So unless we can really attune or customize our hand washing practices by showing how to manage within tubewell water, how to manage with bucket and mug, how to manage without where the supplies are not piped, how do you do that? Because it's a very insensitive showing of hand washing practice to the rural poor and urban poor where they don't have access to piped water. But so far we have been showing it only for the urban middle class and well-off kind of people. So this, till this date, most of the content producer, with all due respect to everyone, that's what we have been doing, which is very insensitive to the poor class. So that was my observation.
Thank you very much, Khairul Bhai. I think that's a great way to kind of bring this this webinar to a close. Just a few concluding thoughts from me. I mean, just to let you know that this research that we have done is we are taking it to the people who are in the decision-making domain. I mean, many of you are. You all are designing interventions, so hopefully this will contribute. But we are working very closely with RCCE, we have asked them to, we have some propositions for them in terms of how we want to engage with them further. This is the type of formative research that I think whets the appetite and starts providing a framework for us to start thinking. This obviously, it cannot be just taken into operationalization straight away. I think there are more concrete operational work that needs to be done, and that's exactly what we are discussing with RCCE, and hopefully, that's going to come to fruition. Now, in terms of some reflections from me, so number one, I think it's all about context and details. right? I think we often forget that. So it's all about how we translate, but it's also about how we pay attention to real details of how everything is going to be actually implemented and used. So if we are respectful of usage, and if we are really focused on effectiveness, and then I think we can work out the details and we can basically customize. So I think context and details is sort of really about context and details, and not about kind of uncritical transfer, as Shahiduzzaman Bhai said. I think the second point is, I think what Shahiduzzaman Bhai also said about structuring the reality, and this is really, really important, because I think there is a big role to play in an epidemic crisis kind of a situation to structure the reality, because kind of people's individual rationalities are just too biased and too compromised out of fear and out of all kinds of other irrational biases. So the importance of structuring the reality is really, really important. And I think that's a really important concept to really sort of take forward. So these were the kind of two thoughts I basically had in terms of concluding thoughts. We are going to be pursuing, as I said, with RCCE, this line of research, because we believe that behavior communication change is at the heart of this tackling this crisis, not only right now but also in the longer term, because this is not going to be kind of off and on type of a crisis. This is going to be more like it's going to have a long tail of impact. So I think we need to behavior change and communication is going to be a central idea that we need to really take seriously. Finally, I would like to let you know our next webinar. We'll let you know the time, but it's going to be, we've been doing some media tracking on violence against women and domestic violence. We will be making that presentation at some point very soon, hopefully sometime this week, but we will get back to you with dates on that. Otherwise, thank you very much, and please take care of yourself. Thank you.
Thank you, everyone.